Welcome back to the deep dive. Today, we are turning our attention to a structure that is, well, it's simultaneously taken for granted and absolutely vital to cardiac function.
It really is.
It's the surrounding shell of the heart, the tough little sac that dictates how the heart fills and beats, the pericardium.
It's the ultimate paradox.
Yeah.
We never really talk about the pericardium until it becomes a problem, until it's pathological.
Right.
But when it does, the resulting diseases, they range from severe painful inflammation to these purely mechanical problems that can restrict blood flow and lead to rapid, life-threatening compression.
And that's exactly the mission for this deep dive. We're going to navigate that entire spectrum of pericardial disease. We need to unpack everything, from the common, often viral-triggered inflammation, what we call acute pericarditis, all the way to the life-threatening high-pressure state of cardiac tamponade.
And then the slow, relentless crush of chronic constriction.
Exactly. This is really about understanding the mechanics of how the heart reacts when its own protective outer layer turns into a physical cage.
And we've drawn on the most authoritative clinical texts for this to make sure we're getting the most thorough, diagnostic-focused look possible.
Mm-hmm.
We really need to zero in on those crucial diagnostic nuggets.
The tells.
The tells, exactly.
Yeah.
The things that separate one life-threatening condition from another.
So before we get into what can go wrong, let's define this structure. When we talk about the pericardium, what exactly are we defining anatomically?
Okay, so you're looking at a double-layered sac that surrounds the heart and the big vessels coming off it, the proximal great vessels.
Double layer.
The inner layer is the visceral pericardium. It's a serous membrane, and it's basically plastered right against the epicardium, which is the surface of the heart muscle itself.
Okay.
Then outside of that, you have the tough, more rigid outer layer, the parietal pericardium. That one's fibrous. It's much less compliant.
And between those two layers is the space where all the magic, or I guess all the trouble, happens.
That's it, the pericardial space. Normally, it contains a tiny, tiny amount of fluid, a lubricating ultrafiltrative plasma. We're talking 15 to 50 milliliters.
So a few tablespoons at most.
Not even that, really.
Yeah.
And that small volume allows the heart to beat and move smoothly within the chest cavity without, generating friction with every beat.
So why is this shell even necessary if it holds so little fluid? What are its day-to-day jobs?
Well, it has several biomechanical functions we often overlook.
Yeah.
First, it's a physical restraint. Think of it like a safety belt for the heart.
A safety belt. I like that.
It prevents the sudden, excessive dilation of the cardiac chambers, particularly the thin-walled right atrium and right ventricle, especially during periods of high demand like intense physical exercise.
So it maintains the heart's optimal geometry under stress.
Precisely. Second, it physically anchors the heart, restricting its anatomic position so it's not just, floating around in the chest. And third, it acts as a very useful physical barrier. It slows down or can even prevent the spread of infections from nearby structures.
Like from the lungs or the pleural space.
Exactly.
Okay, but here's where it gets really interesting and frankly a bit surprising. We talk about it being protective, yet the sources make this fascinating counterpoint. If you are born without a pericardium, a congenital absence, or if it's surgically removed completely,
the outcome is usually benign.
right, most people show no obvious clinical disease.
That's the paradox we mentioned earlier. It is fundamentally non-essential for immediate life support. You can live a perfectly normal life without a complete pericardium.
But there's a catch.
There is a critical caveat. While total absence is usually fine, partial defects are not.
How does a partial defect become so dangerous?
So if you have a small hole or a gap in the pericardium, it creates this rare but truly catastrophic risk. The heart tissue itself, usually the left atrium or sometimes a part of the ventricle, can actually herniate.
It pokes through the hole.
It pokes through that hole
Yeah.
and can become physically strangulated. It's an acute mechanical obstruction that can cause sudden death. So the structure's fine when it's all there and it's fine when it's all gone, but it can be disastrous when it's only partially compromised.
That sets the stage perfectly for what happens when the sac remains but becomes inflamed. Let's pivot to pathology, specifically to the most common problem clinicians face here, acute pericarditis, the fiery, inflamed sac.
Right. Acute pericarditis is just inflammation of the pericardium, often from an infection or some systemic cause. And when a patient comes in with chest pain, the clinician relies on a constellation of 4 principal features to confidently diagnose it. You really have to check off these boxes.
The first, and I imagine the most urgent concern for everyone in the room, is the chest pain. It's so easily confused with a heart attack.
Indeed, the pain is typically severe rectosternal, so right behind the breastbone or over the left side of the chest. It can radiate, often to the neck and arms, but the classic radiation point for pericarditis is the shoulder or, even more specifically, the trapezius ridge.
That muscle on top of the shoulder.
Exactly. And that radiation is thought to be mediated by the phrenic nerve, which innervates that whole area.
Yeah.
So if a patient mentions pain right on that muscle ridge, that is a massive clue.
But the real differentiating sign, the thing that really separates it, is positional, isn't it?
Absolutely vital.
Huh.
Characteristically, this pain is intensified dramatically when the patient lies flat on their back, supine, because that position just increases the physical pressure and friction between the inflamed heart and the chest wall.
And the relief comes from?
The relief comes when they sit up and lean forward. Patients often describe it as the prayer position, or they'll curl up. It physically pulls the heart away from the chest.
So if they are rigid and clutching their chest, you're thinking heart attack. But if they're constantly shifting and finding relief hunched forward, you're leaning toward pericarditis.
It's the positional changes that often break the tie. But, we have to caution the listener that pain isn't always present. Pericarditis can be slow onset and totally pain-free in certain cases, like in uremic pericarditis from renal failure, or if it's related to radiation, cancer, or tuberculosis.
Okay, moving to the second diagnostic feature, the sound of trouble, the pericardial friction rub.
The rub is pathognomonic, meaning it's uniquely characteristic, and it's audible in the majority of patients, something like 85% at some point during the illness. It's the literal auditory signal of the two inflamed layers rubbing against each other.
And what does it sound like?
Clinicians describe it as rasping, scratching, or grating. It truly sounds like dry leather rubbing against itself.
And it's notoriously tricky to catch, right? I've heard it can be very transient.
It is. It's highly dynamic. It can come and go over hours, so repeat examinations are essential. You listen for it best at the end of expiration with the patient sitting upright and leaning forward, which physically minimizes the distance between your stethoscope and the heart.
And it has different components.
Yes, a unique aspect is that it often has up to 3 components corresponding to different phases of the cardiac cycle: atrial systole, ventricular systole, and then early ventricular diastole. It's a very distinctive sound if you can catch it.
Okay, let's talk electrical signals. Feature number 3, the evolving ECG changes. This is where we shift from physical examination to reading the consequence of this inflammation on the heart's electrical system.
The ECG changes are a direct result of that subecardial inflammation, and they progress in a recognizable 4-stage pattern. In stage 1, the acute phase, we see widespread ST segment elevation across almost all the leads, except usually for AVR and V1.
And the key morphological differentiator here versus a heart attack is the shape of that ST elevation.
Absolutely critical. In acute pericarditis, the ST elevation typically has an upward concavity. Think of it like a smiley face or a shallow upward scooping curve.
Right.
In contrast, the classic acute myocardial infarction, a true heart attack, usually features an upwardly convex or dome-shaped ST segment. It looks more like a tombstone. That shape difference is a huge tell.
That upward smile is the first clue. What else happens in stage 1?
We also see PR segment depression. The PR segment reflects the atria, so depression here strongly suggests that the inflammation has involved the atrial muscle. It's a condition we often call perimyocarditis. This PR depression is another high-yield diagnostic finding.
And then the sequence unfolds over time.
Exactly. Over several days to a week, the ST segments return to the baseline. That's stage 2. Then and only then, in stage 3, do the T waves become inverted.
The sequence is the key.
The sequence is everything. The T waves invert after the ST segments have already normalized. This timing is the exact opposite of what you typically see in a heart attack, where the ST-T wave changes often evolve together much more rapidly.
And stage 4 is just the resolution.
Correct. Weeks or months later, the ECG returns to normal, though sometimes abnormal T waves can persist for a long time. But tracking that sequence, ST up, ST back, T down, is a classic textbook pattern.
Finally, the 4th feature is pericardial effusion, the accumulation of excess fluid.
Right. Any fluid over that normal 50 milliliters is an effusion. If it develops slowly, it might be entirely asymptomatic. But if it's large or it accumulates rapidly, it starts causing mechanical compression.
What are the clinical signs of that?
Clinically, large effusions muffle the heart sounds, making them sound distant or quiet. They could also cause the friction rub and the normal apical impulse to disappear. And on a chest X-ray, if there's enough fluid, the heart silhouette can appear globular and large, sometimes described visually as a water bottle configuration.
Which brings us back to that crucial distinction between pericarditis and acute myocardial infarction. We've covered the ECG morphology and the timing, but let's talk biochemistry, the blood tests.
This differential is the one that clinicians fear most, because the treatments anti-inflammatories versus anticoagulation and reperfusion are diametrically opposed. Mixing them up can be fatal.
Absolutely.
In pericarditis, the inflammation is superficial, meaning it just involves the subepicardium. This can cause a modest amount of injury to the underlying heart muscle.
And that injury would release cardiac biomarkers like troponin into the blood.
Exactly.
Yeah.
So you can see a rise in myocardial damage biomarkers, suggesting an associated epimyocarditis. However, and this is key, the rise is typically very modest, slight, and transient.
Unlike a heart attack.
It's nothing compared to the massive, dramatic, and sustained elevation you see in a true AMI, where a large chunk of muscle tissue is actively dying.
So if we see those widespread ECG changes, the upward concave ST segments, but only a tiny blip on the troponin test, that dissociation is a very strong piece of evidence for pericarditis.
It's extremely helpful, especially when you pair it with the clinical history and that positional chest pain. And speaking of history, the timing of the symptoms themselves is another tiebreaker.
Walk us through that timeline one more time.
In the most common form, viral or idiopathic pericarditis, the patient often reports having some nonspecific flu-like or viral illness about 10 to 12 days before the chest pain starts. Then, the fever and chest pain develop almost simultaneously.
Whereas in a heart attack.
In a true AMI, the severe chest pain is the immediate crisis. It's what brings them in, and it often precedes any fever or other systemic symptoms. The clinical timeline is absolutely critical context.
That deep dive into the acute inflammation gives us the what. Now, in part 2, let's explore the why, looking at the vast spectrum of causes or etiology and how clinicians classify the disease based on its time course.
Right. The clinical timeline is the first piece of classification because it informs our suspicion about what complications might be brewing. If the disease lasts less than 6 weeks, we call it acute, and that usually manifests as fibrinous, which is dry or effusive with fluid. If it continues for 6 weeks up to 6 months, we call it subacute. This is the period where we start to worry about these overlap syndromes like effusive constrictive or pure constrictive forms starting to develop.
In the dreaded chronic stage.
That's anything lasting over 6 months. And that typically manifests as chronic constrictive pericarditis, a rigid, scarred sac, or sometimes chronic adhesive pericarditis, which is scarring without the restriction.
Now on to the laundry list of triggers. Let's start with the most common infections.
Statistically, the most common trigger is presumed to be viral, even though we often don't isolate the specific virus. That's why we end up grouping so many cases under the idiopathic label.
Right, we just don't know for sure.
We don't. But known viral culprits include Coxsackie virus A and B, which are the classics, along with various herpes viruses, adenovirus, and mumps. In the last few years, we've also seen increasing links to post-acute COVID syndrome, HIV, and even Mpox.
Viruses are usually self-limited, but certain bacterial infections.
Okay.
You mentioned these are an immediate aggressive threat.
Pyogenic or bacterial pericarditis is a genuine medical crisis. Organisms like pneumococcus, streptococcus, or staphylococcus can get into the sac, often secondary to an overwhelming systemic infection or a procedure nearby. This means pus in the pericardial space.
A very dangerous situation.
The prognosis is very poor unless it is immediately and aggressively managed with surgical drainage, followed by high-dose targeted antibiotics. You cannot afford to wait on this one.
And on a global scale, the most stubborn infectious enemy remains tuberculosis.
Absolutely. Tuberculous pericarditis remains a massive public health concern, especially in developing nations, and it's often complicated by endemic HIV infection. TB can lead to virtually any pericardial presentation, a massive effusion, chronic constriction, or that effusive constrictive hybrid. It's an insidious disease that demands specific, prolonged therapy.
Beyond infection, the body can trigger this inflammation in dozens of non-infectious ways.
Oh, the non-infectious triggers are wide-ranging and often related to systemic disease or physical trauma. First, you have renal failure, what we call uremic or dialysis-associated pericarditis, where toxins build up and irritate the sac.
Makes sense.
Then there's neoplasia, or cancer. Metastatic disease from lung, breast, lymphoma, or leukemia often spreads to the pericardium, leading to large and often bloody effusions.
Trauma and surgery also show up frequently on this list.
Yes. Any direct trauma to the chest can cause bleeding into the sac. An aortic dissection, where the major vessel tears, can leak blood right into the pericardial space, causing rapid tamponade. And of course, an acute MI itself can cause a local inflammation, which brings us neatly into the autoimmune category.
The body turning against its own damaged tissue.
Precisely. We categorize these as autoimmunity or hypersensitivity. This includes the major collagen vascular diseases like systemic lupus erythematosus or SLE, rheumatoid arthritis, and scleroderma. Also, certain drugs like procainamide or hydralazine can induce a lupus-like syndrome that specifically targets the pericardium.
Let's focus on the post-cardiac injury syndromes, including the historical Dressler syndrome. What makes this group unique?
It's all about the timing. Dressler syndrome originally referred to pericarditis after a heart attack, but the umbrella term now covers pericarditis after any kind of injury, surgery, trauma, or MI.
So what's the mechanism?
The theory is that the initial injury releases myocardial antigens, which then triggers a delayed immune response. The key clinical clue is that the symptoms don't develop immediately. They typically pop up 1 to 4 weeks after the initial cardiac insult.
So a patient feels fine leaving the hospital after surgery, then gets chest pain 3 weeks later.
You have to think post-cardiac injury syndrome. It's a classic delayed presentation.
Given that acute idiopathic pericarditis is the most frequent presentation, let's detail the standard treatment protocol. What is the modern regimen?
The cornerstone is high-dose anti-inflammatory therapy and rest. We start with bed rest and either very high-dose aspirin, we're talking 2 to 4 grams a day, which is a massive dose.
Wow.
Or high doses of non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, 600 to 800 milligrams 3 times a day.
And because of those massive doses, gastric protection is completely non-negotiable.
Absolutely. Pairing the NSAID or aspirin with a proton pump inhibitor like omeprazole is essential to prevent severe GI side effects or ulcers. The initial high dose is maintained for a week or two, and then, and this is crucial, it's tapered extremely slowly over several weeks to prevent a relapse.
But the real game changer in treating pericarditis, especially recurrence, has been the introduction of colchicine.
Colchicine is mandatory now for almost all acute idiopathic cases, unless it's contraindicated. It's often given for 3 months, sometimes even longer, depending on the recurrence risk.
And how does it work?
It works by interfering with inflammatory cells, primarily neutrophil migration. By adding colchicine to the NSAIDs, we significantly enhance the response, and most importantly, we dramatically reduce the risk of it coming back.
And recurrence is the chief complaint of these patients, isn't it? The frustration of it.
It is. About a quarter of patients with idiopathic pericarditis will have a recurrence, which can be disabling and so frustrating. Colchicine cuts that risk immensely. But it does come with a major GI side effect, diarrhea, and it's contraindicated in patients with severe liver or kidney problems.
Now let's talk about the big anti-inflammatory guns.
Yeah.
Steroids or glucocorticoids. Why are they treated with such caution in this context?
They are reserved only for cases where NS and colchicine have failed, or for patients who have specific underlying conditions that respond only to steroids, like certain autoimmune diseases. The caution is severe because high-dose corticosteroids are known to increase the risk of subsequent frequent recurrence.
That seems so counterintuitive. Why does a powerful anti-inflammatory drug promote future attacks?
It's thought that the rapid sledgehammer suppression of the initial inflammatory response prevents the body from achieving a complete lasting resolution. So when the steroids are removed, the inflammation flares back with a vengeance, often worse than before.
So if you have to use them.
If you must use them, they have to be tapered rapidly over just 2 to 4 days as soon as the patient improves to minimize that systemic dose duration.
And for those poor patients who suffer from chronic, disabling, frequent recurrences, sometimes for years, what's the last line of defense?
At that point, you're moving into specialized territory. We might employ immunosuppressants like azathioprine or increasingly biological agents like anakinra, which is an interleukin-1 beta receptor antagonist. This targets the inflammatory pathway directly, often with excellent results, but these are typically managed by specialists.
One final, absolutely critical warning that ties directly into our next topic, the use of anticoagulants.
Yes, this is a major clinical safety point. Anticoagulants must be avoided in acute pericarditis. The inflammation makes the already delicate pericardial surface prone to bleeding. Giving blood thinners significantly increases the risk that any small bleed will rapidly turn into a large hemorrhage within that closed pericardial space.
And that would instantly convert a stable inflammatory condition into a catastrophic, life-threatening cardiac tamponade.
Yeah.